One of the greatest obstacles to crafting health and wellness is identifying and controlling inflammation. It's at the core of all complex and chronic diseases, and it's the driving mechanism that underlies the most common symptoms that people like you struggle to overcome. Join us as we explore cutting-edge science and research to give you the information and tools you need to create the quality of life you want and deserve. And now, here is the host of Inflammation Nation, Dr. Stephen Noseworthy.
Hey there, everybody. It's Dr. Noseworthy with the Inflammation Nation podcast, and I know everyone's been waiting for me to get to the actual 5 pillars of hormone balance and control. But before I do that, I want to give just a huge shout out and thanks to everybody in the Inflammation Nation who's been listening to the podcast since we launched in January. This past week, I don't know exactly when it happened. I was teaching a seminar to a bunch of medical doctors in Raleigh, North Carolina. But somewhere between when I entered the conference room and when I exited, we turned over 10,000 individual downloads with the Inflammation Nation podcast. And we did that in just about 5 months. And that's all because of you guys. And so my heartfelt thanks to everybody who listens and likes and subscribes. If I can only get you guys to start commenting, sending questions in, it would help guide some of the topics that I choose to talk about. All right, so let's go ahead and let's talk about the 5 pillars. What I'm going to do is I'm going to list them first, and then we'll probably spend one episode on each of those. And today we'll talk about the first one, which is insulin and blood sugar control. And I think I've mentioned that before, but let me give you the list first, and we'll come back and we'll talk about insulin and blood sugar. So here are the 5 pillars of hormone balance and control. And remember, the whole concept here is that when you are looking at someone who does have some kind of a hormone imbalance, and I'm just going to use that as a generic term, there are many different ways that hormones can be abnormal, if you will. But there is a foundation of metabolic control that allows hormones to be balanced and to work the way they're designed to. And that set of foundational elements includes, number 1, insulin and blood sugar control. Number 2, stress chemistry, or oftentimes we'll hear terms like adrenal fatigue, adrenal exhaustion. Not always entirely accurate. If you remember my lessons on cortisol, we talked about how adrenal fatigue and exhaustion are really not physiologically correct concepts or terms. Nevertheless, we still use it because it captures a mental image. But there's a lot of stress chemistry issues that include increased activation rather than decreased cortisol. And there are different states of dysregulation where certain times during the day cortisol can be high, cortisol can be low in the same day. That's number 2, stress chemistry. Number 3 is gut health. And that will span a gamut of inflammation, different types of toxins or lipopolysaccharide molecules, concepts like leaky gut, whether or not someone's got infections, do they have upregulated beta-glucuronidase and are affecting detoxification, as well as the health and the balance of the microbiome. That's number 3. Number 4 is detox capacity. And that's actually a pretty broad topic. In fact, I just a couple of months ago, just released, I haven't promoted it yet, but I released a self-learning module, if you will. It's multiple modules, but it's called 3D Detox, the new science of detoxification. And you can check that on my website if you want to. But it's basically a self-guided instructional on how to do detox based on current science and current understanding. There's a lot of misconceptions out there, a lot of old school tactics that are being promoted by a lot of people. So detox capacity, and that includes things like liver enzyme activity or glutathione sufficiency, or what actually is your chemical load or your chemical burden, and do you have chemical reactivity? And we're going to talk about all of these once we get to each of these individual foundational pieces of hormone control. And then finally, that was number 4. This is number 5, is your general inflammatory load. And this has a lot to do, particularly when there are inflammatory type symptoms that accompany hormone imbalances and hormone dysfunction. And so for a guy, it could simply be, hey, I've got low testosterone symptoms and my joints and my muscles hurt. For a woman, typically it manifests with things like pelvic or breast pain during their menstrual cycle. And there's different ways, but those are the big clues. And so the general inflammatory load, we know just very quickly impairs pituitary signaling as well as hormone receptor sensitivity, again, promoting pain with PMS-type symptomatology. And one of the key factors here is actually the prostaglandin diet that ends up being derived from, prostaglandin profile that ends up being driven by your diet. So how you choose to eat can actually change your inflammatory profile. So those are the 5 pillars. The first thing that we want to talk about is insulin and blood sugar control. And even though we've talked about this kind of stuff in prior episodes in the Inflammation Nation, and we'll probably end up talking about it again just because it's so foundational and fundamental to all human function. We just end up talking about it in different contexts. But basically, there are 2 types of blood sugar dysregulation. We have what we might call low blood sugar patterns. They would be things like functional low blood sugar or functional reactive hypoglycemia or functional hypoglycemia. And then we have high sugar patterns, which typically are kind of characterized by high glucose and insulin or insulin resistance, which is the mechanism by which we get metabolic syndrome and start marching our way towards, say, type 2 diabetes. And so there's a scale and a spectrum, and there's a continuum. So low blood sugar and high blood sugar patterns. And one of the key things to understand here is that if somebody says to you, high blood sugar is the cause of something like PCOS in a woman, and we'll talk about PCOS specifically in this episode, there is kind of a misconception that there always has to be a high blood sugar element to this. In reality, it's not the high blood sugar or the high glucose that's causing the metabolic disturbance in these conditions. The problem is actually erratic or constantly elevated insulin levels. And I'll hold on to that for a second, just simply because I need to tease out that detail with a little bit more detail when we get to talking about something like PCOS. But really, when we talk about high blood sugar or insulin resistance, we're really talking about periodic elevations of insulin or chronically elevated insulin, like we would see in insulin resistance, metabolic syndrome, or type 2 diabetes. So one of the things, like, people will say, well, how do I know if I have a blood sugar issue? Well, there's a couple of things you can do. Number one is you can do lab testing, and that helps a lot. But even if you have what someone might say is a fasting blood sugar that's too high or too low, if you don't have the dysfunction or the symptoms that go along with that, then you probably don't have that issue. And here's a classic example. Let's say that, this might be a little bit too detailed, but we'll do it anyways. Let's say that you have 2 people who have a fasting blood sugar of 103. And on face value, both of those people will be told that their blood sugar is a little bit too high. They need to, do whatever, eat less carbohydrates, exercise more. But that number by itself doesn't tell us actually who has the problem. We want to know, is somebody symptomatic with it? Do they have things like post-meal fatigue or cravings, especially if they eat too many calories or too many carbohydrates? That's the classic and the hallmark high blood sugar pattern, if you will, symptom pattern. But we want to be a little bit more discerning from the laboratory standpoint, simply because fasting glucose is just a very mono or one-dimensional metric, and it doesn't tell you all that much. You might have 2 people with a fasting blood sugar of 107, I think I said. Again, it's just an example. And maybe one of those people fasted for, 16 hours and the other person only fasted for 7. Or maybe they got up in the morning and, had half a bagel before they realized, hey, I'm going to get my blood sugar done or my blood test done, and so I should probably not finish the bagel. So context really is important. Now, if you assume that both people were fasting for decent amount of time to get clean readings, if you will, on a fasting blood sugar, the next thing you want to know is how much insulin is involved in creating that fasting blood sugar value. Because insulin and glucose, of course, work together. As you eat and your blood sugar goes up, it triggers the pancreas to release insulin. And how much insulin gets released is going to be dependent on 2 things. Number one, how high is your blood sugar? So more insulin will be required with higher levels of blood sugar. But also, to what degree are you or are you not insulin resistant or sensitive? Meaning that if you and I ate exactly the same meal and our blood sugar goes up exactly the same amount, if I have some degree of insulin resistance and you don't, my body's going to need more insulin to clear that glucose than you will. And so maybe a fasting blood sugar of 107 is not all that concerning if somebody has a single digit fasting insulin level, whereas the next person has the same fasting blood sugar of 107, but their fasting insulin is like 28. Those are two completely different clinical scenarios. And so we have to be careful about just pegging things or hanging our hat, if you will, on the value or the presence of one marker. We want to, of course, and this is something I teach in seminars all the time, we kind of have to be part-time masters of human physiology and understand how to test for the things that we're actually interested in. So before I go too far down that bunny trail, let me get back to talking about insulin and blood sugar and the impact on hormone balance and control. One of the ways that you can figure out if you have a blood sugar issue, aside from going to the lab and getting some blood sugar or blood work done, is to simply ask the question, what happens when you eat? If you eat and you feel better because before you ate you weren't feeling great, then you probably have a low blood sugar issue. We might be able to put a label on it, a tentative label of, we used to call it reactive hypoglycemia, but probably a functional hypoglycemia might be a better term, or a functional low blood sugar. So if you eat and you feel better, chances are your blood sugar was too low. However, if you eat and you feel worse, especially if it's a lot of calories and especially if it includes a lot of carbohydrates, and particularly if it's post-meal fatigue or cravings for things like sweets or stimulants like coffee or nicotine, then you probably have a high blood sugar issue. So that relationship, basically what should happen is you get hungry, you eat, and you're no longer hungry. You shouldn't have any change in function, either function coming back and improving or function getting worse associated with eating. The other way we can think it is just flip it around and ask the question, well, what happens when you skip a meal, or you fast for 16 hours, or you just wait too long in between meals? If you feel worse when you skip a meal or wait too long to eat, then again, think you have low blood sugar. But if you feel better, think that you might have high. Now, there are a lot of exceptions to those general rules, but those general rules tend to serve us pretty well. But that is again the big picture. So remember, it's really the insulin. It's not necessarily the blood sugar, and this trips up a lot of docs because I do a lot of case consulting, either going over cases with docs like in our downtime at seminars and conferences, or I actually use that as a service. I have docs that hire me to coach them through difficult cases that we're working with. And sometimes they'll be confused, like, Doc, I don't get this. This is like a skinny, low blood sugar person who has PCOS. And they're like, well, that doesn't fit the textbook, because the textbook says that women with PCOS have, they're overweight, they carry around extra body fat, and they have high male hormones, and they have insulin resistance. And that's true. That's very, very common. But there's kind of, let's call it an atypical presentation with something like PCOS, where you can have a skinny woman with low blood sugar. The problem is not the low blood sugar or the absence of the high blood sugar. The problem is when you have someone who has this low blood sugar state, they tend to overeat. Like when their function crashes and they have a low blood sugar attack, if you will, they get hangry, then they typically eat anything and everything in sight, and it's usually crap. It's usually full of sugar and all this kind of stuff. And so their blood sugar surges up. And along with that is a spike in insulin, and that takes time to come down. And so you can actually have insulin surges with periods of insulin elevation that can dysregulate a female's hormones, even though they don't fit the classic picture of you're overweight and you have a high blood sugar condition. I think I jumped the gun on that because I was planning on talking about that in just a little bit. But I'll come back to that. There's nothing wrong with giving you a little preview and then coming back and reiterating the highlights, because when we look at the spectrum, certainly men can have problems with hormones. We'll talk about that very briefly. Again, it's a simple conversation because male hormone systems are very simple. But in women, obviously, we have a spectrum that's based on where they are in their reproductive age, and their hormonal systems are more complex. So remember, it's not necessarily just what's happening with your blood sugar. Is it too high? Is it too low? It's really also about, and this is where the pathophysiology comes in, it's about the insulin surges or the constant state of elevated insulin. And you can have that with both low blood sugar as well as high blood sugar. So, that's a key point there. So let's talk about men quickly, and then we'll move on to ladies. In men, what tends to happen with the insulin and blood sugar problems that cause dysregulation is what we call andropause. And some people jokingly call it menopause. But basically what ends up happening is, let me back up 1 second. Men's male hormone profiles, we want that to be androgen dominant, right? So we want more testosterone than we have estrogen. We want more testosterone than we have progesterone. But the key relationship there is actually the testosterone as well as the estrogen levels, and that ratio needs to be appropriate. And so what ends up happening with men who have these either insulin surges periodically or constant elevated insulin because of insulin resistance is it triggers an enzyme called aromatase. And I've mentioned this before. It's one of our key hormones, but what it does is in both men and women is it converts male hormones into female. It takes testosterone, for example, and makes estradiol. Testosterone is our standard hormone for male hormone comparison in terms of strength and metabolic impact. There is a higher or more impactful, more powerful male hormone called dihydrotestosterone, but testosterone is what we have most of, and it's what does most of the work, if you will. And that can be converted directly into estradiol through this aromatase enzyme. And that aromatization, that process, is natural also in women. It's natural in men because men too also need estrogen. We just don't need as much as a female does. And so when a guy has these problems with blood sugar control and either has erratic insulin surges or has constant high insulin because of, say, an insulin resistance or prediabetes condition, then the aromatase enzyme gets upregulated and that converts more testosterone into estrogen. And what we start to see is that the ratio between the two starts to shift. So testosterone goes down within its optimal range, estrogen goes up within its optimal range. And to be honest, the values don't necessarily ever have to go outside of the lab range or outside of the functional range, but sometimes we see the manifestation of this when the ratio is off. And so again, you can have a functionally low testosterone and a functionally high estrogen in a man, and that can cause a lot of problems. And so what is andropause? Basically, it's a lack of vitality, vigor. Basically, guys, they get less spontaneous morning erections. It's harder to maintain erections. They lose that sense of vigor that kind of makes them want to go out and conquer the world and do dangerous things. And so their hormonal profile changes, their mindset and their behavioral system changes as well. And that's about as simple as it gets, or as complicated as it gets. We won't go into things like gynecomastia and like feminization, but that can happen in smaller percentage of cases. It's not like every guy who has blood sugar issues or insulin issues is going to end up with feminization of characteristics. But certainly what we see is an increase in fat mass, adiposity, increased risk for cardiovascular disease, cerebrovascular disease, as well as changes in, say, let's just call it male performance. Now, that's a quick encapsulation of how insulin and blood sugar can affect hormones in men. Well, what about women? I've said several times that it just depends on where they are in the reproductive life cycle. So there's another enzyme called 1720 lyase that women have that increases the production of androgens from the ovaries. So yeah, the ovaries actually make testosterone. That's what an androgen means, male type hormones. And so with these blood sugar patterns, either low or high, that result in erratic or intermittent insulin surging or chronically elevated insulin from a hyperglycemic state, we get an upregulation of 1720 lyase, and that increases the production of androgen. And this can lead to premenstrual type symptomatology. It can lead to polycystic ovarian syndrome, as well as infertility in those reproductive age women, and then also contribute to peri and postmenopausal symptoms as we start thinking about women that are in later life stages. But because it is the most common endocrinological or endocrinopathy in women, let's talk about PCOS or polycystic ovarian syndrome. It's the number one cause of infertility. It's one of the main causes of premenstrual symptomatology. Actually, let me rephrase that. The underlying mechanism that leads to PCOS is the same mechanism that leads to most of the PMS symptomatology. But PCOS is the most common endocrine imbalance in reproductive age women. And in the US, it affects not quite 10% of the population, which is a huge number, when you're looking at over 300 million people for sure. But all of the textbooks, all the research review articles pretty much agree that the main cause and contributing factor is, now you'll read it as it says insulin resistance, but I will caution you that it's insulin elevations that can occur both with low as well as high blood sugar. Insulin resistance really only occurs with high blood sugar states, but periodic insulin elevations, if they're happening long enough or frequently enough, can lead you to the same place, which is the PCOS. So it's not only high blood sugar. It's a little bit of a misdirection. Just to highlight some of these other relationships, metabolic syndrome is twice as common in patients with PCOS compared to the general population. And patients with PCOS are 4 times more likely than the average person to develop type 2 diabetes. And so there's this intimate link between the high blood sugar states, the mechanism that drives metabolic syndrome, insulin resistance, leading into your prediabetes and your diabetic conditions. Now, how do we diagnose PCOS? Well, something called the Rotterdam criteria for diagnosis, which I think the Endocrine Society promotes. You might see some alternate other opinions that are out there because, there's no central authority that says it shall be this way, but this is what's generally accepted, is that there are 3 potential criteria and you have to have 2 of those. You have to be able to exclude other causes of what you're seeing clinically, and they have to have 2 of these 3 different potential findings. And one is high male type hormones, which again is coming from the poor blood sugar control, but specifically the hyperinsulinemia. So high male hormones called hyperandrogenism, and that's easy to figure out just by doing blood or saliva testing. We can also see ovulatory dysfunction, and there's some more specific tests that deal with that I'm not qualified to do. I'm not going to go into it, but that would be done by an endocrinologist who specializes in reproductive health. And also then polycystic ovaries, actually seeing cysts and doing diagnostic imaging. And the test of choice for that is a simple test. It's a non-invasive test called a transvaginal ultrasound. And I say non-invasive in the fact that it doesn't pierce the skin, but without getting too graphic, an ultrasound probe, if you will, is inserted into the vagina, and then the imaging is done from the inside. So I guess it's invasive in that sense. And so when we start looking at PCOS and start looking, number one, it's the number one cause of infertility. It's very common. It's tightly linked to insulin-based disorders, most commonly high blood sugar, high insulin, prediabetes, diabetes. But we can't forget the atypical case, which is also relatively common, where we have the lady who's not overweight. She doesn't carry excess body fat. She has low blood sugar, not high blood sugar, but she has such erratic eating patterns and such poor quality in terms of her content of her diet that she gets these periodic insulin surges because she just crashes and consumes tons of sugar and carbohydrates. And so insulin drives up, and then it sustains for a while, and then it happens again and again and again. And so one of the things that I'll do, and of course, testing for fasting glucose and hemoglobin A1C and fasting insulin, this is just part of a baseline evaluation. Like anytime that I work with a new client, like a one-on-one coaching client, and we talk about the labs that we want to do initially to figure out what we're dealing with, I have a set of labs that I consider my initial evaluation panel. And it always includes all of those markers just because it is part of fundamental human metabolism and physiology. So let me just back up and I'll zip through this one more time in a minute or less. The issue when it relates to blood sugar control and being able to shift or not shift hormones, it's really about the insulin level. And so testing fasting insulin becomes pretty important. And what ends up happening is that either the insulin surges or the chronic elevation of insulin in hyperglycemic states will change hormone balance by upregulating different hormones that lead to different hormone outputs. So for a guy, it's aromatization, conversion of testosterone into estrogen, changing the ratio of male to female type hormones, which affects male type function. And then with women, it's the upregulation of an enzyme called 1720 lyase, which increases the production of androgens from the ovaries. That's where it comes from. and then promotes things like ovulatory dysfunction and polycystic ovaries. Now, what is a polycystic ovary? Well, basically, think about every time in the menstrual cycle when a woman is supposed to ovulate. If the ovulation doesn't happen properly, and what ends up happening is that the follicle that was released doesn't get resorbed and it gets encapsulated into this cyst-like thing. And if that happens multiple times, you end up with polycystic ovaries. And you can have multiple small polycystic ovary presentation, or you can have larger ones. They can be painful. They can be asymptomatic. The only way really to know is to do something like a transvaginal ultrasound. And so a typical workup from my perspective, if I have a woman who I think has a problem with something like PCOS, is number one, to do good labs and to look at the, I shouldn't say standard because most docs don't do this, but look at fasting glucose, the hemoglobin A1C, an enzyme called lactate dehydrogenase, looking at fasting insulin at the same time, and using what's called the HOMA calculator to get a numerical value for whatever the degree of insulin resistance is. And we can calculate all that based on mathematical algorithms that are published in the medical literature. And so we'll do that, and then we'll do hormone profile to look for evidence of increased male-type hormones, and that would be androstenedione, testosterone, and dihydrotestosterone. Those are the three male-type androgens. And we'll also do a transvaginal ultrasound. I don't often find the need to send someone out to an endocrinologist to have more specialized testing to look at things like ovarian reserve and all that kind of stuff. We typically find what we need just simply by doing good blood work, by doing a saliva test or a blood test to look for male-type hormone elevation, and then doing a transvaginal ultrasound to look for polycystic ovaries. Now, that same mechanism, and I'll clue it up here in a second, is it's the same mechanism, although obviously women who are perimenopausal and postmenopausal are obviously not ovulating. All right, that's just part of that stage of life. But nevertheless, we can still see the upregulation of the 17-20 lyase. Now, as long as a woman hasn't had like a hysterectomy where the ovaries are taken out, then her ovaries may still be able to produce small amounts of these androgens. But in the peri and the postmenopausal state, really what ends up happening is the increased production of androgens coming out of the adrenal system. And this is where the 5 pillars start to interlink. And so I'm going to leave that there as a teaser, because the next pillar that we want to talk about, of course, is stress chemistry and adrenal balance. Hey, thanks again for helping us get to 10,000 downloads. It's a big milestone, and we look forward to the next 10,000 and hope you're still with us. Take care. We'll talk to you again soon on the Inflammation Nation. Thank you so much for listening to the Inflammation Nation. If you found this episode valuable, please rate, review, and subscribe to our podcast. Be the first to know when a new episode drops so that you can stay on top of your game. It also helps others like you find the answers they need. And why not head over to my main website, drnoseworthy.com, that's drnoseworthy.com, to explore my personalized functional medicine coaching programs, submit a question to the podcast, maybe take a quiz, or even reach out to me using the contact form that you can find there. We'll see you next time.